Here's something that completely frustrates me to no return. Your hips hurt. You've told, say, 3 different doctors exactly where it hurts, when it hurts, and how it hurts. Your MRIs look normal, your x-rays look normal, all your tests are literally normal. And the doctors say, I don't see anything wrong. But you're not imagining this. The pain is real. It's limiting your life. You've been dealing with it for months, even, I don't know, maybe years. You've seen multiple doctors. You've done physical therapy. You've tried the medication, and the pain, it has a pattern, a very specific pattern. And it starts in your hips, but it doesn't just stay there. Sometimes it shoots down your leg, maybe. Sometimes it shows up in your lower back. Sometimes it shows up in your groin, but it's consistent. It happens in the same way, in the same sequence, triggered by the same activities. Yet, every doctor has looked only at your hip joint because that's what they're trained to see. Fractures, tears, arthritis, structural damage. What they're not trained to see is the pattern that's going on. There are 5 specific hip pain patterns that show up over and over in women specifically, or I should say, especially after pregnancy. Each one has a signature, a specific sequence, a predictable progression. Each one has a root cause that imaging just doesn't capture. And each one gets misdiagnosed as normal findings or non-specific hip pain because doctors aren't trained in pattern recognition for functional movement dysfunction. They are trained in structural diagnosis, and your problem isn't structural. So before we get into like the 5 patterns, you need to understand something fundamental. Based around medical training is built around anatomy and pathology. Anatomy is like what structures exist and where they are. Pathology is what happens when the structures are damaged or diseased. This is structural based medicine. Bone's broken, fix the bone. Ligaments torn, repair the ligament. Cartilage worn down, replace the joint. Clear cause, clear solution. This works great when the problem is structural, but what about the structure is normal and the function is not? What about when muscles aren't firing in the right sequence? When joints are unstable, not because ligaments are torn, but because motor control is disrupted. When some muscles are overworking to compensate for others that aren't working at all. This is functional dysfunction. And it doesn't just show up on an MRI. It doesn't show up on an x-ray. It shows up on how you move. Let me give you an example. In a normal squat, here's what should happen. You got your core engaged first, so you're going to stabilize your spine. You got your pelvic floor coordinated with the core. You have your glutes activated to control hip descent. Your hip external rotators keep knees aligned, and movement is smooth, controlled, and pain-free. In dysfunctional pattern, here's what actually happens. Your core does not get engaged. It gets weakened during pregnancy. Your pelvic floor doesn't coordinate, trauma from childbirth, and your glutes don't activate properly. That's a neural inhibited. Hip flexors try to compensate and take over. Your hip joint compresses abnormally and pain results, but both of these look identical in an MRI. All the structures are intact, no tears and no damage. But one creates the pain and dysfunction and one doesn't. The difference is the pattern, the sequence, and the coordination of the muscles that activate. Medical training spends years teaching structure. It spends minimal time on function and movement patterns. Physical therapy training does cover movement patterns more extensively, but standard orthopedic PT often uses generic protocols rather than the detailed pattern analysis. And insurance only covers basic PT, not comprehensive movement assessments. So these patterns go undiagnosed. Now let me show you the 5 specific patterns that show up commonly in women with hip pain. Pattern number 1, the anterior hip grip. This is probably the most common pattern in postpartum women. The pain location is front of the hip, deep in the groin, sometimes rotating down the front of the thigh. So when it hurts, it's like getting out of your car, going from sitting to standing, first steps in the morning, lifting your leg like you're putting on your pants, and you're lying on that side at night. What it feels like is a deep pinching or gripping sensation, like something is catching or stuck. What shows up on an image is usually nothing, sometimes a mild labral fray, but not enough to explain the symptoms. Common diagnosis is hip impingement or early arthritis, or maybe it's just a tight hip flexor. Here's what actually happening. During pregnancy, your core and pelvic floor essentially stops functioning normally. They had to make room for the baby. After pregnancy, they're supposed to return to normal function, but often they don't automatically restore their coordination. When your core isn't stabilized, your pelvic, your hip flexors try to do that job. Your PSOAS, that is the main hip flexor muscle that starts working overtime. They stay contracted, trying to stabilize. They never fully get to relax. This creates that grip sensation that you might feel. It also creates an abnormal compression in the front of your hip joint, which can irritate the labrum over time, even though the labrum itself isn't torn. And when you go to lift your leg, that already tight hip flexor have to contract even more, creating that pinch you feel. This is why stretching that hip flexor just doesn't solve it. You're stretching a muscle that is tight because it's overworking. The problem isn't that it needs to be longer. The problem is that it needs to stop compensating. What actually fixes the pattern, you can do these little steps. Step 1, it would be restore core function, specifically your deep core activation and coordination. I cannot stress that step enough. Once you strengthen your deep core, just watch everything fall into place. You're going to retrain your pelvic floor coordination. So it works with the core. Then you're going to release your hip flexor over activating through motor control training, not just stretching. Then we're going to reintegrate normal movement patterns so your hip flexors don't take over again. This process takes about 8 to 12 weeks of consistent retraining, not 6 sessions of a generic hip strengthening. Woman comes in 14 months postpartum, pain in her right hip for 8 months. She has seen 2 doctors. The MRI shows mild labrum fray, no significant findings. 6 weeks of standard PT, your hip flexor stretching, your glute strengthening, no improvement. Then you get a referral specialized movement assessment. Assessment is found, so your core is not activating during movement, your pelvic floor is not coordinating with the breathing, your hip flexors are firing at 150% normal activation, glutes barely activating. So the treatment specific retraining protocol. So between like week 1 and 2, your pelvic floor and your core coordination. Say week 3 and 4, your hip flexor release with motor control. Week 5 and 8, movement patterns retraining. Week 9 and 12, you're going to integrate all this into your daily activity. Your results, Pain will reduce with, say, 80% by week 6, fully resolved by week 10. You're going to have a follow-up MRI. Still shows the same mild labrum fray. The structure didn't change. The function did. The pattern was the problem, not the structure. You got pattern number 2 is the lateral hip overload. This pattern shows up as pain on the outside of your hip. The pain location would be side of the hip over the bony prominence, sometimes rotating down the outer thigh to the knee when it hurts. Lying on your side at night, classic sign. Walking upstairs, standing on one leg, crossing your legs, and then after sitting for extended periods, so like a long car ride and such, or working at your desk. What it feels like is like a burning, aching sensation on the outside of your hip, sometimes sharp with certain movement. What shows up on imaging is often IT band syndrome. Common treatment, cortisone injections into the bursa. IT band stretch, maybe ice. This provides temporary relief, say 6 to 8 weeks if you're lucky, but the pain comes back. Why? Because they're treating the inflammation, not the cause of the inflammation. So here's what's actually happening is when you stand on one leg, which you do with every step when you walk, your pelvic should stay relatively level. So there's 3 muscle groups working together to keep your pelvic stable. You got your glutes medius, so those are the sides of your hip. Your deep core is around your spine, and your pelvic floor is the bottom of your pelvis. During and after pregnancy, the core and pelvic floor are prized. This leaves the glutes medius trying to do the job of all 3 muscle groups. It's complete overloaded. The glutes medius attacks to the greater that bony prominence on the side of your hip. There's a bursa there, a fluid-filled sac that provides cushion between the muscle and the bone. When the muscle is constantly overworked, it creates an extensive friction on the bursa. The bursa becomes inflamed. The bursitis is the symptom, not the cause. Cortisone injections reduce the inflammation, but the muscle is still overworked. So the inflammation comes back. This also affects the IT bands, which run down the outside of your thigh. The IT bands connect to the same lateral hip muscle. When these muscles are overactive, the IT bands get tight, creating pain down your outer thigh. This is why stretching the IT band just doesn't solve it. You can't actually stretch the IT band. It's not that kind of tissue. What actually fixes the problem is you're going to restore deep core stability so it can do its job. Then you're going to retrain your pelvic floor so it contributes to the pelvic stability. Then we're going to release glute medius over activity through motor control work. Then you're going to retrain single leg stability with all 3 systems working together. Then gradually load the correct patterns with your walking, going up and down the stairs, running. So you're looking at your timeline being 6 to 10 weeks typically. Here's a real example for you. A woman, 2 years postpartum, twins, right hip pain for 18 months, had 3 cortisone injections. Each worked for 6 to 8 weeks. Then pain returned. Recommended surgery to remove the bursa. She sought a second opinion from a movement specialist. What the assessment showed was 0 core activation during single leg stance. The pelvic floor was completely discoordinated. Glutes medius firing at about 200% on the right side. The pelvic dropping severely on the left side during the right leg stance. Treatment, 10-week retraining protocol. Results, Pain reduced about 70% by week 5, resolved by week 9-ish. So 18-month follow-up, still pain-free, no injections needed, no surgery needed. The pattern was the problem, not the bursia. So if another pattern for you is the posterior chain collapse. This pattern involves the entire backside of your body, but it shows up as hip pain. So your pain is located, can be in multiple places. So like lower back, SI joints. So that's where like your pelvis meets your spine. Your deep buttocks, hamstring attachments, sometimes sciatic symptoms. The pain migrates. It moves around. 1 week it's in your lower back, the next week it's in your hips, next week it's in your hamstring. This confuses doctors because pain that moves around doesn't fit structural diagnosis. When it hurts, could be like bending forward, lifting anything, standing for a long period of time, transitioning from sitting to standing. End of the day, what it feels like is deep, achy, sometimes sharp with certain movements, feel unstable or weak in like your back hip area. When you get your imaging done, it might show often normal, sometimes a mild disc bulging or SI joint inflammation, but nothing dramatic. Common diagnosis is non-specific low back pain or SI joint dysfunction. Common treatment is low back, PT exercises, core strengthening, maybe an SI joint. Results, minimal or temporary improvement. What is actually happening? Posterior chain is connected system of muscles. So you got your deep spinal stabilizers, glutes, hamstrings, pelvic floor, mainly in the back portion. During pregnancy, this entire system gets disrupted. Your center of gravity shifts forward as your belly grows. Your labrum spine hyperextends. So there's excessive ache in your lower back. Your pelvic tilts forward. This position lengthens and neurologically inhibits your glute. Your hamstrings try to compensate for non-functioning glutes. Your lower back muscles overwork to control the excess ache. After pregnancy, this pattern often persists. The glutes don't automatically turn back on. They've been neurologically inhibited for 9 months. Your brain essentially forgets how to activate them properly. So the hamstrings and your lower back muscles continue doing the glutes job. But they're not designed for sustained posterior support. They fatigue. They develop trigger pain. They develop trigger points. They hurt. Without the glutes stabilizing the pelvic, the SI joint becomes unstable. The ligaments get stressed, inflammation develops, the pain patterns develop. So in the morning, you get stiff lower back from muscles being tight all night long. By midday, your SI joint pain from instability with movement. Evening, deep buttocks pain as muscles are completely fatigued. Different days, the patterns show up in different locations depending on which compensating muscles is most fatigued. This is why standard lower back PT just doesn't do it. Standard PT strengthen your core, stretch your hamstrings. The primary problem is glutes inhibition and posterior chain coordination. Until you restore glute function and posterior chain coordination, everything else is compensating. What actually fixes the pattern? You're going to restore glute activation through specific neuromuscular re-education. This isn't just do glute bridges. It's retraining your neural pathways. The next step would be you're going to release overactive hamstrings and your lower back muscles. Then we're going to restore pelvic neural positions. So you're going to correct that anterior tilt. Then you're going to retrain posterior chain coordination. So your glutes, hamstrings, spinal stabilizers, they're all going to be working together in proper sequence. Next, is progressively load the correct patterns. Your time frame would be 8 to 14 weeks. This pattern takes longer to correct. I'm going to give you a real example. Woman, 3 years postpartum, pain started during pregnancy and never resolved. Described pain as moving around, sometimes low back, sometimes your SI, sometimes deep in her buttocks. Seen 5 providers, primary care, chiropractor, orthopedic, pain management, physical therapy, multiple diagnosis, SI, joint dysfunction, labrum strain. You just need to strengthen your core. Basically what was told. Patient was frustrated, feeling like she was falling apart or would never be able to exercise again. Comprehensive movement assessment showed that her glute firing at less than 30% of normal, hamstrings doing all the work during hip extensions, pelvic anterior tilt of 15 degrees normally is about 5 to 10, complete posterior chain discoordination, compensatory low back overactivity. 12-week retraining protocol focused on glute reactivation. So started with the basic positions, progressed to functional. Posterior chain coordination, pelvic repositioning, hamstring release, movement pattern reintegration. So the results would be week 4, pain reduced about 40%, starting to feel glutes working. By week 8, pain reduced about 75%, able to walk without pain. By week 12, pain reduced 90%, back to running. 6-month follow-up, complete pain-free running 20 miles a week. The structure was never the problem. All those MRIs showed mild findings were accurate. The pattern, the posterior chain collapse, was the problem. Another pattern is the rotation restriction. This one is subtle, but really affects your daily life. Pain location would be deep in your hip joint, often hard to pinpoint exactly, somewhere in there. When it hurts is like getting in and out of the car, putting on your shoes and socks, squatting down, sitting cross-legged, rolling over in bed, during and after sex. What it feels like is restriction, tightness, like something is blocking full range of motion. Not sharp pain necessarily, but uncomfortable limitations. What patients say is my hip hurts, my hip feels stuck, or I can't move it all the way, or sometimes doesn't hurt right in there. So what imaging will show is usually complete normal, sometimes mild FAI, so it's an impingement. Actually very common and often not painful. Common diagnosis is tight hips or hip impingement, or you just need to stretch more. Common treatment is hip mobility exercises and stretching yoga. Results, minimal improvement. Might feel slightly better during the stretch, but restriction returns. This is what's actually happening. The hip joint is a ball and socket joint. It should have good range of motion in all directions, including rotation. Rotation is controlled by a small, deep rotating muscle. It's also intimately connected to your pelvic floor function. The pelvic floor and deep hip rotators share neural pathways and fascia connections. During pregnancy and especially childbirth, the pelvic floor experiences significant trauma, stretching, sometimes tearing, nerve disruptions. The brain's protective response is to lock down that area. The pelvic floor stays tight and guarded. The deep hip rotators, neurologically connected, also tighten, but they are not tight because they need to be stretched. They're tight because they're guarding and protecting. It is protective muscle tension. Their neurological response, not flexibility problem. When you try to rotate the hip, you hit this protective wall. It feels like a structural restriction, like bone hitting bone. It's actually muscle guarding. This is why stretching just doesn't work. You're trying to force through protective tension. The brain responds by tightening in even more. This is also why all those hip openers in yoga doesn't help this pattern. Pigeon pose, 90-90 position, they're stretching the outer hip. But this restriction is the deep rotators in the pelvic floor coordination. What actually fixes this problem is you're going to restore pelvic floor function and reduce protective guarding. This requires gentle, gradual retraining, not stretching. Then you're going to release your deep hip rotator guarding through motor control techniques. Then you're going to retrain coordinated hip rotation with pelvic floor coordination. Then we're going to go into integration into functional movements. So you're squatting, transitioning positions, daily activities. Time frame for this is about 6 to 10 weeks. Key point is this isn't flexibility problem requiring more stretching. It's a neurological coordination problem requiring retraining. A woman 18 months postpartum emergency C-section complains of right hip feeling stuck, couldn't cross right leg over left, difficult getting in and out of car, uncomfortable during intercourse, tried yoga for 6 months, all the hip openers, no improvement. Saw an orthopedic, got her x-ray, showed mild FAI. The recommendation is you can try PT, but you might eventually need surgery for your impingement. Decided to try specialized PT evaluation first. Assessment, it showed severely restricted hip interior rotation, pelvic floor completely hypertonic, overly tight, deep hip rotators and protective spasms, pain with pelvic floor palpations, history of perineal tearing during first delivery. Treatment focused on pelvic floor training, learning to relax, not strengthen. Deep hip rotators released through motor control, gentle rotating, retraining with breath coordination, integration into daily activities. Your result, week 3, noticed hip loosening up. By week 6, could cross legs comfortably. By week 8, full rotation restored, no restrictions. Sexual functions improved significantly. Never needed surgery. The mild FAI or x-ray is still there, but it's never was the problem. The protective guard pattern was the problem. Another pattern, I think we're on 5 now, the load intolerance. This one is particularly frustrating because it stops women from being active. The pain can be anywhere in the hip depending on which compensation is failing. So the key characteristics is that hip feels fine with normal daily activity, but pain starts with walking long distance, exercising, so like running, hiking, cycling, carrying kids for extended time, standing for long periods, any sustained or repetitive loading patterns over time. First 10 to 15 minutes, you feel fine. 20 to 30 minutes, discomfort starts. 40 plus minutes, significant pain, have to stop. Next day, you're sore and stiff. What it feels like, my hip is fine until I try to do anything. Then it just falls apart. What imaging shows is normal. Maybe mild findings, but nothing to explain the symptoms. Common diagnosis is you're probably just doing too much too soon, or deconditioning, or maybe you need to build up slowly. Common advice is start with 5 minutes and gradually increase. What happens is you start following that advice. You start slow, you gradually increase, and it still hurts once you get past a certain threshold. You're stuck at a low level of activity, never able to get back to what you could do before. Your body has a system for distributing load during movement and activity. When working properly, multiple muscle groups share the work. Your core stabilizes the spine, your pelvic floor stabilizes the pelvic from below. Your glutes control your hip movement. Smaller stabilizers fine-tune the movement. Each muscle does a specific job. When the load is distributed properly across all these muscles, you can sustain activity for extended periods. After pregnancy and childbirth, some of these muscles aren't functioning properly. You have a core weakened, pelvic floor dysfunctional, maybe your glutes inhibited. The load doesn't get distributed across all the muscles that should be sharing it. Instead, fewer muscles are doing all that work. At first, for 10 to 15 minutes, they can handle it, but they're doing more than their share. They're fatigued faster than they really should. When they fatigue, pain starts. If you push through, they get increasingly overloaded, leading to significant next day soreness and stiffness. This is load intolerance. Not because you're weak or deconditioned, but because load distribution is dysfunctional. This is why start slow and gradually progress just doesn't work. You're still using the same faulty load distribution patterns. When you walk 5 minutes or 30 minutes, the pattern is still the same. At 5 minutes, the compensating muscles haven't fatigued yet. At 30 minutes, they have. Your progression hits a wall at whatever duration exceeds the fatigue threshold of your compensating muscles. What actually fixes this pattern is you're going to identify which muscles aren't contributing to load distribution. Then you're going to restore function of those muscles, usually your core, pelvic floor, and glutes. And then you're going to retrain proper load distribution during the movement. You're going to build capacity and endurance with the correct patterns. Now you can progress loading gradually because the pattern is fixed. This usually takes about 10 to 16 weeks. This takes time because you're building new capacity. Women 2 years postpartum, avid runner before pregnancy, trying to return to running, could run 10 miles before pain started. Followed all the return to running advice, walk run programs, started at 1 minute running intervals, progressed over 3 months to 10 continuous minutes. Couldn't get past that threshold. At 10 to 12 minutes, hip pain started. Frustrated, feeling like she'd never be able to run again. The movement assessment showed that core not activating during running gait, pelvic floor not coordinating with impact, your right glute media is fatiguing rapidly, and excessive pelvic drop on the right side after 10 minutes, compensating with hip flexors and IT bands. The treatment approach was restore core stability during gait, retrain pelvic floor coordination with breathing and impact, then fix glute activation and endurance, correct pelvic floor stability during single leg load, gradually rebuild running capacity with correct pattern. Results by week 6, running 15 minutes comfortably with corrected form. By week 10, running 30 minutes. By week 14, running 45 minutes. By 6 weeks, completed a half marathon, pain-free. The capacity was never the limiting factor. The faulty load distribution pattern was. Fix the pattern and you could build the capacity. Why do doctors miss the pattern? It's not because they're bad doctors and they just don't care. It's because how they're trained to think about the pain. Medical training focused on pathology. What's wrong with the structure? Modern diagnosis is heavily imaging based. If imaging is normal, they're taught the problem is either not serious, be stress, anxiety, deconditioning, you just need to get stronger. Functional movement pattern dysfunction, creating chronic pain despite normal function, isn't in this diagnostic framework. It's not what they learned in the medical school. And assessing is required watching the person move. Literally the time they don't have. Understanding motor control. Training they didn't get. Comprehensive history about pregnancy and birth. Not part of orthopedic intake. Pelvic floor assessment is not in their scope. Insurance doesn't reimburse adequately for this kind of assessment. So it doesn't happen in standard orthopedic care. Physical therapists aren't trained more extensively in movement patterns. But standard orthopedic PT is limited by short session times, 30 to 45 minutes with multiple patients sometimes. Limited number of approved sessions is about 6 to 8. Pressure to follow standardized protocol. May not have specialized postpartum training. Pelvic floor physical therapists have this specialized training. But the hip pain doesn't usually get referred to pelvic floor physical therapy. It gets referred to orthopedic PT, different specialties, different training focus. So women fall through the gap. Pattern-based dysfunction is a structural-based diagnosis system. These 5 patterns show up over and over. Hip grip, lateral hip overload, posterior chain collapse, rotating restriction, load intolerance. Each one predictable, each one treatable. Each one missed by standard structural diagnosis because doctors aren't trained to look for patterns. They're trained to look for pathology. When pathology isn't there, they say everything is normal, but it's not normal. The pattern is the pathology. It's just different kind than they were trained to actually see.